pessoal, estamos aqui mais uma vez em Chicago durante a cobertura do AUA 2023 no SBU-SP em situ, e agora um momento especial. Nós vamos falar com o professor Neal Shore. O professor Neal Shore foi o apresentador do estudo EMBARK, um estudo que avaliou o paciente M0 sensível à castração, ou seja, aquele paciente com recidiva bioquímica, onde talvez a gente tenha agora uma mudança de jogo. A gente vai ter uma nova opção de tratamento que talvez seja melhor do que a hormonioterapia isolada. Eu vou deixar ele falar um pouquinho mais sobre isso, mas é um grande poder falar aqui com o Dr. Neal Shore. So, Neal, we just presented during the AUA the EMBARK study. Do you think it's going to be a game changer? Please tell us a little bit about the study design and what were the results.
Yeah. Well, thank you, Marcelo. Always great to speak to my colleagues in Brazil. Bom dia. We started this trial in 2015. First patient in January 2015. Last patient enrolled in August of 2018. And we had the top line readout in the middle of March 2023. A little over 1,000 patients, all with biochemical relapse, had to be high-risk biochemical relapse. 75% of the patients had radical prostatectomy and or radiation. 25% alone had radiation. 25% alone had radical prostatectomy. High-risk BCR PSA doubling time of less than or equal to 9 months. Here's the thing. 3 arms in this 1,000-plus patient global trial. The first arm was combining enzalutamide with leuprolide, about roughly 335 patients. The second arm, just leuprolide alone with a placebo control. So those first 2 arms were blinded. And then a third arm, which wasn't blinded, you just received monotherapy enzalutamide. Here's the bottom line. The primary endpoint was metastasis-free survival, comparing the combination to monotherapy leuprolide. A hazard ratio of 0.42 with a p-value of less than 0.0001. So a 56% reduction in the likelihood of a radiographic progression. With conventional imaging, patients were scanned every 6 months. So hazard ratio of 0.42. For the monotherapy arm of enzalutamide compared to leuprolide alone, also statistically significant with a hazard ratio of 0.63. No new safety signals regarding enzalutamide. And of course, everyone knows enzalutamide has been approved for over a decade now, and we have experience in post-chemo mCRPC, non-metastatic CRPC, and metastatic hormone-sensitive prostate cancer as well. So this sort of completes this enormous body of work in trial development for enzalutamide. Other key secondary endpoints, the PSA, RPF, the PSA progression, hazard ratio of 0.07. So if you look at the graph, the PSA progression rate when the combination, it's almost a flat line. It's really remarkable. And similarly, other important endpoints, in addition to time to PSA progression, new anti-neoplastic therapies, all favoring the combination enza-leuprolide over leuprolide alone, and even the monotherapy enza arm also bested the monotherapy leuprolide alone. We're looking at our patient-reported outcomes. We will be reporting on those later this year. So I do think this is game-changing. And as you and I were talking earlier, it's all about appropriate intensification for the right patient at the right time.
Amazing results. I have just one question regarding the clinical aspect of that. So there was no comparison among ENZA and ADT with ENZA as monotherapy. So how should clinicians interpret this data and maybe select the ideal patient for the combination, the intensification, ADT and ENZA, or ENZA alone?
Yeah, it's a great question. We'll be looking at that cross-comparison. As you can imagine, the ENZA monotherapy arm had no ADT, so patients never had T suppression and the associated side effects of that. But again, we're really carefully looking into that data. It's a great question. Of note, at the end of 9 months, if you had a PSA of less than 0.2, you also could experience de-intensification or a treatment holiday. And we're really going over that data. I presented some of it as well at the AUA plenary, but it's a really important concept for quality of life for patients.
Great. And I have also another last question, please. We've seen that these new hormonal agents, they are arriving in an earlier stage of disease. What's the importance for the urologists to understand that this new scenario is a reality, and do you think that we should start prescribing these new drugs in Brazil? Most of the times we refer these patients to the oncologist. There are other studies with other drugs like apalutamide, for instance, in high-risk prostate cancer that are undergoing radiotherapy. There are other studies evaluating these new hormonal agents in the prostatectomy scenario as neoadjuvant or adjuvant therapy. So a message for the urology community of how to deal with these new drugs. They're not so new anymore, right?
Right. No, I thank you. That's a great question. And look, urology is a fantastic field. Uro-oncology is an amazing field. It's always great to work with your medical oncologist and your radiation oncologist. I'm a big proponent of the multidisciplinary team, but I'm a urologist, and so I love our specialty. And for our colleagues who want to take care of patients with advanced prostate cancer, which it can vary how you want to define it. I think advanced prostate cancer begins with anybody you're considering giving ADT to. And so now in the biochemical relapse, we have an indication for an ARPI or a novel hormonal agent or an androgen receptor blocker, depending upon the acronym you like. So if you define advanced prostate cancer as high-risk BCR, and clearly metastatic hormone sensitive, and clearly MCRPC and NMCRPC, we have obvious indications for the use of intensification with an AR blocker such as enzalutamide. But there are other great androgen receptor signaling inhibitors, apalutamide, darolutamide, abiraterone. These are oral agents that I absolutely feel that uro-oncologists in Brazil must adapt. You know, we have so many patients who need our care, and you can work together with your medical oncologist, radiation oncologist, or be able to be comfortable to do it by yourself. And there will be more data coming forward with the use of androgen receptor signaling inhibitors in high-risk patients who will be receiving ADT and radiation, as we historically know that works, but now also adding on an androgen receptor signaling inhibitor. So, Marcelo, your point is so well taken. There's really almost no consideration now where you wouldn't be thinking about an androgen receptor signaling inhibitor. We have a luxury of choosing multiple ones. These are oral agents. The safety tolerability profile is well described.
Perfect. Thank you very much, Dr. Neal. It was a great pleasure to talk to you. Congratulations for the work. I really think it will be a game-changing, and maybe this monotherapy arm could be even more researched so that we can decrease the instance of side effects. And the future is very bright and very exciting. Thank you very much. Obrigado, pessoal. Então, mais uma entrevista importante aqui para o SBU in situ com o professor Neal Shore, e nos vemos ainda aqui em Chicago. Até mais.